Okay. 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 So hello. Thank you for all being here today up to this hour. So in the next few minutes, I'm going to present you valve-in-valve implantation with the Allegra device. I have nothing to declare. So the patient is an 84-year-old male who has worsening shortness of breath and fatigue the last 6 months. He has a history of surgical aortic valve replacement back in 2017 with a mitral flow of 23 millimeters. And he had a net rate repair of his mitral valve with a Pascal device in 2018. He also has Waldenstrom macroglobulinemia and hypertension. So his transthoracic echo, I will show you some images later on, showed the maximum velocity of the aortic valve to 4.1 and a mean gradient of 40 millimeters of mercury, and an estimated AVA of 0.9. His ejection fraction was good, and he had a mild residual mitral regurgitation. Euroscore was 5.1, and STS score 5.78. So he was on toracimide, olmesartan amlodipine for his hypertension, cilospir, and pantoprazole. This is his coronary angiogram. You can see his coronary arteries have no stenosis. And this is the echo showing the good LV function and the aortic stenosis with the mean gradient of 35 millimeters of mercury. With these views, you can appreciate the good movement and location of the Pascal device with the mild residual pulmonary regurgitation. So this is the CT angio. You can see that the peripheral vessels are very good with very mild atheromatosis. And on the left side, you can see the position of the Pascal device and the mitral flow. So more measurements in the CT. So we have the diameter and the perimeter of the valve. We have the height of the coronaries. More measurements just to make sure. And then we have this. We have our patient with the valve 23 millimeters, which is a fractural valve. And based on the application, we have different options, self-expandable and balloon expandable, just to choose. So we went with the Allegra device. The Allegra device is a superannual valve who received the CE mark for TAVI back in 2017, and then for a valve-in-valve in 2020. So one of the basic characteristics of this valve is that it has a squeeze to release mechanism. So this is the orange button you can see, and in a position with the other valves that have to twist to release, and the implantation goes through 3 steps. The permaflow, the inflow release, where at that point you can receive the valve for repositioning, and the final detachment of the valve. This valve is from bovine pericardium, and as I already told you, is a supraannular valve. So this is the aortography, where you can see the aorta and the Pascal device. And on the right slide, you can see the pigtail in the left ventricle. The invasive hemodynamics, you can see that the mean gradient was 52, severe stenosis. And this is the Allegra device. And you can see the markers in the mid of the valve, which are quite characteristic, and they are in alignment. And this is the second phase of where you can see that the valve opens very quickly and not gradually compared to other valves. Here we can see that the opening and the final position of the valve, but we can see some residual regurgitation. Therefore, we went for a post-dilatation with Osipka balloon. And these are the final hemodynamics, where you can see that the mean gradient is 6.4 millimeters of mercury now. And we always go back and see the puncture site just to make sure we don't have any issues with the vessels there. We didn't have one. And the final transthoracic echo showing that the mean gradient post-op is 50 millimeters of mercury and a very good position of the valve. Thank you for your attention.
Okay, this was a great case. We have 4 moderators. So it is Dr. Tsiafoutis, Dr. Tranterlis, Dr. Kafkas, and Dr. Tsinkas. Are there any comments?
Yes, congratulations for your excellent presentation. What do you believe is the main reason, the advantage for using, the main advantage for using Allegra device for valve-in-valve?
I was expecting this question. So, to be honest, I'm the only person who shouldn't answer to your question because I'm the heart failure specialist of the department. So I would transfer the question. I know the answer, but it's better to transfer the question to Dr. Katsianos, who was in fact in the operation room. Okay.
Thank you, Dr. Kafkas, for this really good and precise question. Here in this valve-in-valve, we could choose either a balloon expandable or a self-expandable valve. We didn't choose the balloon expandable because the inner diameter of this surgically placed valve is 19 millimeters. And if we put in, for example, an Edwards valve, we would be -2 millimeters. So we would have a diameter of 17 millimeters. So it would be obligate to fracture the valve that could have also a potential risk. So we chose a self-expandable valve. It has a better hemodynamics, and Allegra had a bigger cells for potential access to the coronaries, and it also has the advantage that is resheathable. And of course, has a CE mark, as Dr. Kourkoveli said, because not many self-expandable valves have CE mark. So that was the reason that we chose for Allegra.
Thank you.
Any other comments?
May I continue the comment?
Yes, Grigoris.
Initially, I would like to congratulate all the organizing committee, to thank for the kind invitation. Sorry for not being there. To continue the comment, if you wanted provisionally to fracture the valve, do you have any experience with Allegra? How do you believe that would face a problem regarding the stand and the position of the valve?
So, in my knowledge, we haven't fractured Allegra yet. So, I'm not quite sure about the hemodynamics post-fracture. But if Dr. Katsianos has a different,
Excellent, but depends on the fracture. Will be before or after? I think
the question is the provisional technique if you face problem regarding the gradient after the positioning of the Allegra. Because you know, we don't have a great experience in Greece with Allegra. That's why the question regarding the fracture.
Yes.
Actually, it was also our first Allegra case, so we also do not have the experience this specific issue.
It's a learning process, so maybe in the future.
I think there's no valve that you know it's going to do well when you fracture it. It's better to do the fracture and then implant the valve. I don't know what the rest think about this. Dr. Kilits, do you prefer to fracture before a valve? Yeah. What do you suggest? Fracture before or late, after? After?
It's just like a stone. So it is the recommended approach also, not valid, but when you use the application, it's always said that please implant the valve first and then fracture.
Okay, but you know, some schools say better fracture before.
But I think there
It
are
depends
papers.
on the valve type, but in this kind of valve, I recommend to put the valve first, then fracture.
But do you think there is any special valve that it's better? You are not worried you cannot do a fracture? Because the question was if Allegra is good for fracture. I think all valves
are same.
Special
I
question,
think, for this.
Adonis, sorry. The special question is because Allegra is, I could say, an open cell stent device. Probably it's, there are differences regarding the forces against the ring of the valve. That is the question. I don't have experience at all, really. And, it's a very honest question to more experience than me.
No, that was a good question, but I don't know if there is a clear answer. Yeah. So maybe we should move to the next case. Okay, thank you very much.
Thank you.
Yeah.